Hi, everyone. Welcome to Arthritis at Home. I'm so happy to see you again. My name is Cheryl Cohen. I'm with Arthritis Consumer Experts, and we are the host of Arthritis at Home. It gives me incredible pleasure, as it always does, to be joining you today with Dr. Susan Bartlett. Hello, Doc.
Hi, Cheryl. Lovely to join you.
Dr. Bartlett is a professor of medicine at McGill University and an adjunct professor of medicine at Johns Hopkins Medicine. You're originally from London, Ontario, and you completed your master's in psychology at McGill and a PhD in clinical psychology at Syracuse University and a postdoctoral studies at Johns Hopkins. And you now are working in rheumatology and clinical epidemiology, and you are a rare breed actually in rheumatology, in that you're one of few with a PhD in psychology that practices in the area of rheumatology. We're going to do something I think which is going to be really fun and talk to our audience today about recent work that you presented at the American College of Rheumatology.
Neuro-QOL Upper Extremity Function Scale, new opportunities to more reliably and precisely measure function and self-care in RA.
Okay, there you go.
This was actually a project and a presentation that received a lot of attention at EULAR earlier this summer.
Yeah.
In rheumatoid arthritis, we use physical function as a really important marker of really how active the disease is, because one of the first things that happens is you can't do all of the things that you want to do. But, you know, most of the measures of physical function that we still use, they were developed in the 1970s or 80s, and they ask about mobility, the lower extremity, activities of daily living. So, Cheryl, you'll remember back to the old days.
Yes, I will, sadly.
And, you know, in the old days, within 10 years, everybody was in a wheelchair.
Yeah.
And so what happened is the large joints, first the small joints are affected, and then the large joints were affected.
Yeah.
And most of these questions, unfortunately, focus on the large joints. We're in a different era. It's the hands, it's the feet that tell us that a person has inflammatory arthritis. And then we move into action quickly. And with the new medications and the new approaches to treatment, we stop it. We stop it in its tracks before it gets to the larger joints and has ability to destroy larger joints.
Yeah.
But we still use these measures that ask about the activities that involve the larger joints.
Yeah.
So that was the purpose of doing this study, is that we had, there are a family of measures known as the PROMIS measures, Patient-Reported Outcomes Measurement Information System. This was developed by the National Institutes of Health about, well, almost 20 years ago now. There is a PROMIS physical function measure, and it's very good. And we've been using it for a number of years, and it's been widely adopted in many rheumatology settings and in clinical trials now for at least 10 years. It's recommended by the American College of Rheumatology. But there's a sister set of questionnaires called Neuro-QOL. And Neuro-QOL are PROMIS measures, but for patients with neurological disabilities. We got particularly interested in a Neuro-QOL scale because Neuro-QOL had an upper extremity measure.
Okay.
And so it asked about the function of the hands. And the whole purpose of this process was, this project rather, was to say, if we measured what was going on in the hands, how the hands were being affected, would we get better, more reliable information than if we ask using our old clunky measures that ask about mobility and how far can you walk. And the reason for this is because in our clinics, the two clinics in which I work, which is at McGill and at Johns Hopkins, we would notice that on our regular physical function measures, half of the people were scoring 0, which meant we didn't have any information about half of the people because, well, their large joints hadn't been affected. So what we did was we compared how well the Neuro-QOL upper extremity measure worked compared to our traditional measures, and we found, not surprisingly, that when you ask about the hands and what people are able to do, and that's things like pick up a coin or use a pen or brush your teeth, things that are very specific to the hands, that we got much more specific information.
Yeah.
And that when people's disease level was changing, the change in the scores was much, much bigger. So, for instance, even with a PROMIS score, the average change was about 5
Yeah.
when somebody said they were a lot better or a lot worse. On Neuro-QOL, it was 9. So,
Yeah, this is unbelievably important work. And you're so right, Dr. Bartlett, that when I mean, all most of my joints were affected before my disease was well controlled. But I'm one of those olden day gals. So I was diagnosed at 27 when we had just very sort of the medications that were available did really next to nothing. I might have gotten 20% of my life back out of a loss of 100% of it when I was diagnosed. And you're right. I think about the questionnaires I filled out back then. I'm still filling them out now, and they're meaningless to me.
yep.
And patients actually get really frustrated at filling these things out. And mostly we fill them out to gain reimbursement for a medication. So you think about that, kind of how twisted it is. We're filling out forms that actually don't even measure the things that are of greatest importance to us, that then go on to show that we do qualify for reimbursement of a medication. They're measuring the wrong things. And so this is a bit crazy making to us as patients. So I'm hearing from you, this is advancing that by light years, because of advances of treatment, where they affect, where we get maybe some early benefit is in these small joints and before it goes to our big joints. Is that right?
You want to ask the right questions, right?
Yeah.
Now, rheumatologists have always asked the right questions, but for instance, here in Quebec, to get on a biologic, you need a HAC score. HAC is one of the original questionnaires, and it was so critically important, and it revolutionized treatment in 1980 when it was released.
Yeah.
But it's still being used, and you need a HAC score of at least 1 to qualify for a biologic. So we're not asking the right questions when we're for our policy level decision.
And it's not, and the hack isn't sensitive, like it very rarely changes. So
that's where I had 50% scoring 0.
Exactly. So I sit there and I fill it out and I'm like, what am I doing here? Why am I doing this? Why is this the thing that either gets me to an effective medication my rheumatologist is prescribing or not? Yeah. So I'm hearing that the Neuro-QOL, and particularly this look at upper extremity function in RA is a bell ringer. It's the way we should be going, maybe.
And it's not the only questionnaire that can be used, but it's great information, and the policymakers are paying attention. And
they are. Okay, good.
Yes, okay, we've got better ways of assessing physical function, and it's just a matter of now getting some consensus on which of the questionnaires can and should be used.
So is there a standardization that you know of, Dr. Bartlett, across the provinces about what, because our membership is coast to coast. The second largest percentage of our membership is in La Belle Provence. And it's very much mirrors the population distribution in the country. And so people like me we are curious. Well, do people in, New Brunswick have to go through this? Are people in Saskatchewan getting what I'm getting? We do worry about these things. Certainly at ACE, we do, as one of the leading advocacy organizations in the country. So in your estimation, are policymakers using a similar set of tools like this Neuro-QOL?
I would love to be able to say you that they are, but not at this stage. We're still at the point of trying to get attention and trying to get the conversation going. And you've been really instrumental in that.
Okay.
Because
there
are huge differences from province to province that you have been very vocal about.
Yeah.
And we've seen it with COVID as well.
Exactly.
Differences between the provinces actually harm Canadians. We do need to have policies that all Canadians can benefit from, and one should never have to worry about where they're living in terms of their access to the best treatments.
100%. I couldn't agree more. Dr. Bartlett, these pieces of work are so, if you're not enmeshed in research, if you're not someone like myself who is talking to researchers every day or participating at science meetings, there's a real disconnect between the advances you're making in research and the ground, the grassroots. So we just thank you so much for the work that you're doing. We thank you for partnering with organizations like ours and others that exist in the country, and for putting people really, I've seen it for years now. You do this over and over in your work. You're putting people like myself in the center of forming the question, what's important to us? What's going to make a difference in your life? All of these important questions you're involving us in, and we really do appreciate it so
I
very
think it works
much.
both ways, Cheryl, because all of the questions that I look at, and many of my colleagues now too, come from patients. You tell us what's important. You
Yeah.
tell us where you have the benefit of the lived experience, and you can tell us all the areas where we're not getting it right. And it's very helpful and useful in terms of understanding what needs to happen next.
Thank you so much, Dr. Bartlett. We're really thrilled to have had this time with you. Thank you for the generous amount of time you've given us. Take care, everyone. Thank you for joining. Look at the slide at the end, which will have some links so that you can have some more learnings at your own leisure. Thank you. Bye.
Bye, everybody.